extra chairs here. Thanks. Thanks, Felicity. There's two other chairs over here. One yellow chair here. So if you've got more people coming late, we'll get started. So I think we're going to kick this off. If I had a gavel. Okay. So let's go ahead and get started. I'm really pleased to introduce Monica Wilkie-Brown, Kevin Gabbert to talk about this really important topic. This is obviously a topic that a lot of policymakers are spending a lot of time thinking about, and we've gotten the benefit of quite a bit of federal funding for opioids, and it's continually in the news. I think it was in the notes today again, so it's a very important topic. It's a hot topic. Just last Thursday, I had a chance to talk with Governor Reynolds about this, along with a number of other health-related topics, and brought some information that our staff pulled together with regard to the incidence, the prevalence, admissions, deaths, what's happening on this topic area. And there are some states, I think it would be fair to say, that have been more directly and negatively impacted than we in Iowa have. But that's not to say we can take our eye off this topic and dismiss it. I think we feel as though there are other indicators, one of which is incidence of Hep C, for example, injection drug use, and so those rates are high, so that could be an early sign of more to come. We hope not, but I'm excited to have these two here really to talk about what we're doing in the state. And I think the other thing I would just note too is, and they've both been involved in this, this is really a state government response as well. It's not just IDPH. We're the lead agency on this from a treatment standpoint, and so a lot of the work, we're the epicenter of a lot of the work in this area. But it takes a lot of state agencies who have an interest in this topic to really provide the comprehensive response that's needed. So without further ado, thanks Kevin and Monica for being here.
So welcome everyone. Thank you for coming today. We're going to just be discussing the opioid topic here in Iowa, and specifically the department efforts and other collaborations that are going on that we are aware of and working on. So I'm Monica Wilkie-Brown, and I work in the Bureau of Substance Abuse upstairs. And I'll let Kevin introduce himself and get started.
Hi everybody, my name is Kevin Gabbert with Bureau of Substance Abuse, and I think we'll just go ahead and jump into the presentation. That way, if there are any questions, please feel free to throw those out. So who we are, it's not any surprise to you. We're part of the Department of Public Health, and again, we do this presentation in a variety of different settings, so that's why some of this information's there. Part of the Division of Behavioral Health, which is the single state authority on substance use disorders. And I apologize with us sitting down. I'm usually much more animated and like to wave my hands and walk around and stuff, but we've been told to sit still so we can be recorded. So if I run on a tangent, it's because I've got all this energy built up. So Bureau of Substance Abuse. So we are, as we said, we're in the Division of Behavioral Health, and then within the Bureau is the State Opioid Treatment Authority. We'll talk a little bit more about that. Every state has a SAMHSA designated State Opioid Treatment Authority. I got asked to go to a meeting a couple years ago when the current SOTA was unable to attend, and ever since then, for the last 2 years, I've been known as the SOTA. So be careful what you say yes to when your boss asks you.
All right, so we're just going to go over a few basics about opioids and have some information and then a little quiz that we'll start out with. So if you've heard both the word opiates and opioids, the word opioid is the one that we're using now as kind of the more general term to include also the naturally occurring opiates. There are a lot of different synthetics out there, and they occur both in kind of legitimate medical circumstances as well as illicit substances. And we know, and kind of the most important take-home I think for today is that opioids can have really dangerous effects if either they are consumed in too high quantities for any particular person, or if they're combined with other substances. So that is a really key point that we want to make sure that you know and or remember as you go. And then it's also important to be aware that any discontinuation will cause some withdrawal symptoms. And just like with any other medication, it will probably vary from person to person, and it will depend on how long the use had occurred to begin with, whether that was for medical purposes or otherwise. And one clarification that a lot of people get confused is that an opioid use disorder is oftentimes called an addiction. And that is more than just the physical dependence that I referred to a minute ago when people start to get withdrawal symptoms. So you may be taking opioid medication per your doctor's orders and experience that physical dependence just because that's the way bodies respond to medication of this sort. That does not mean necessarily that a person has an opioid use disorder. It is one of the symptoms that's considered, but it's not the only one. Okay? Are there any questions about that before we move on? That seems like a point of interest to people a lot of times. So, what do you think? True or false? You should never take all the opioid medication that your doctor prescribes. True or false?
False.
False is correct. You should take it as prescribed. However, it is fair to use caution when it says take as needed for pain, because you may not need all 50 pills or whatever they may have given you. And then, where do people, oh, look at that, I gave it away. Where do people get their prescription drugs from when they're abusing these drugs? Almost always family and friends. Okay, so we assume that that second bullet is where everybody gets kind of the drugs that are being misused, but most people are getting them from family and friends, either voluntarily that they're saying, wow, I have this backache, and so their uncle or whoever, cousin is saying, oh, well, I have some leftovers from my last whatever, here you go. Or they might be taking them without your knowledge from your medicine cabinet. If you know anybody or have any medications in your medicine cabinet that are opioid specific, you need to keep track of them and think about getting rid of them if they're no longer serving you. Of course, there is doctor shopping, pill mills, online ordering, and other places that people get prescription drugs, either legitimate prescription drugs or illicit kind of fake prescription drugs that people buy thinking that they are the real thing. And then the last question, true or false? Some people who use opioid pain medications experience more pain instead of less.
True.
Who said true? Yeah, do you know what it's called for extra bonus points? It's actually a condition called hyperalgesia, and it is an increased sensitivity to pain, and it's often thought to be caused by damaged nerves, but is often kind of brought out by the use of opioid medication. So, just something to keep in mind. It doesn't work for everything. So Kevin's going to talk more about being his very special SODA status.
Okay, as I said before, SODA, or the State Opioid Treatment Authority, is a designation provided by SAMHSA. SAMHSA is the Substance Abuse and Mental Health Services Administration. This means that Department of Public Health, we, as the SODA, or in that role, we provide licensure oversight of what we call opioid treatment programs, or OTPs. These are federally recognized entities certified to dispense methadone, and methadone is one of the medications used as part of medication-assisted treatment. I think we talk a little bit more about that here. If not, we'll make sure to address that. We also work kind of as a liaison between the OTPs and SAMHSA. So if there are questions specifically about licensure, about how do certain issues impact our state, then we can then work as the go-between, pose the question to SAMHSA, and then also we advocate for the ongoing use of medication-assisted treatment. Medication-assisted treatment being use of medications, specifically for this discussion in relation to opioid use disorders. So medication-assisted treatment, as I said, it's use of medication to treat addiction. Specific to opioids, there's three different kinds, or three different families. The first is an opioid agonist, and this is, the medication here is methadone. Methadone is an opioid. So a lot of people tend to criticize methadone simply because they say you're just substituting one drug with another drug. The difference is methadone, the way that medication works is that it doesn't provide the intense highs or followed by the intense lows as things like heroin do, some of the illicit types of medications or illicit opioids that are out there as well. So what it does is it helps to reduce withdrawal symptoms and cravings, but not provide that intense high. Okay? So people still think, well, you're still giving them an opioid. The thing I go back to is, who am I to question if a person's happier, healthier, or more productive as a result of taking this medication, as opposed to not taking this medication? Or would we rather have the person out using heroin, which we know, oftentimes is laced with fentanyl, carfentanil, acetylfentanyl, the list kind of goes on in regards to the fentanyl. So, the next type of medication is the partial agonist. These are things, buprenorphine or Suboxone, you may have heard about that. The difference with the partial agonist is that although it does contain an opioid, it also contains another medication called naloxone. And the purpose of that is to prevent diversion. So if a person, because Suboxone or because buprenorphine itself is an opioid, there is a risk of diversion, but by combining it with naloxone, it prevents that from happening. And so this is a much friendlier medication for individuals, for physicians to prescribe to individuals so that they can then take it at home. Whereas with methadone and the OTPs, the drawback is that an individual has to go into that OTP every day to receive their dosing. Yes?
What do you mean by diversion?
Diversion meaning that they're abuse potential. So are they going to try and sell it? Are they going to try and use it inappropriately? And again, great question, and I apologize, you'll probably see several acronyms up here that make no sense. Please feel free to ask and we'll hopefully know what they are. So, so anyway, with buprenorphine or Suboxone, it's a much friendlier medication for individuals that are working on a regular basis. Not that individuals that take methadone aren't. The issue being that with methadone you have to be participating for a certain number of days, a certain number of weeks, a certain number of months, and then you're eligible for take-home doses. Still requires an individual to go into the OTP. It just depended upon how long they've been abstinent, how long they've been involved in the program as to how often they have to go in. And then finally, the last medication is what we call an antagonist. Vivitrol or naltrexone is an antagonist. And what this medication does is that it blocks the opioid, the mu receptor, from receiving any of the opioids. So basically, an individual is prevented from achieving any kind of euphoria or high because of this particular kind of medication. The one downfall to Vivitrol, well, I guess there's a couple things. One is the Vivitrol, it comes in an injectable. It comes in a shot, and the problem is that it's about $1,200 per month per shot. So again, when you're thinking about the population that we're trying to help, some things don't really kind of match up. There are some insurers that are providing discounted rates. The manufacturer, I think, is providing some discounts as well, but just kind of some concerns around that. The other thing is that because it is strictly an antagonist, it doesn't provide that opioid effect so that individuals can continue to have some of those normal functioning, some of those normal types of thought processes, feeling emotions and things like that. So we hear sometimes about people being very angry that are on Vivitrol simply because they're not doing anything else other than receiving an injection.
Yeah.
Kevin?
Yeah.
And you might answer this question later, but maybe I'm jumping ahead, sorry, Van. Do they have to take these medications for how long?
It's all dependent upon the individual. So with the injections, again, we've not heard anything in regards to how often that's happening or for what period of time, but I think we have heard that some people around 6 months, might be kind of the tail off or the average usage amount. With methadone, we've heard of people that have been on it for over 20 years. So it's really just dependent upon the individual. Again, one of the things that we know about prolonged exposure to opioids is that brain chemistry actually changes. And to say that you need to be treated just like every other type of medication, every other type of abuse or addiction, and that once you're off of that, then you just need to go cold turkey, white knuckle it, go to 12-step meetings, and you're going to be fine. That's not the case. And so if we know that this particular disorder responds well to a medication, why wouldn't we continue to do that? So again though, dependent upon what the individual's belief is, that's a conversation for them and their physician. Sorry, healthcare professional. So I've had a conversation with Kathy. We're talking a little bit more about nurse practitioners and MPAs too. So we received the MAH001 grant, or I guess, oh, I'm sorry, we're jumping ahead. We've been doing medication-assisted treatment, or funding medication-assisted treatment for about 20 years through our block grant. In 2007, we received the Access to Recovery grant. We started funding additional types of medication-assisted treatment, whereas block grant was funding methadone. ATR started funding things like naltrexone, buprenorphine, Suboxone. And then in 2015, we received the Medication-Assisted Treatment, Prescription Drug, and Opioid Addiction Grant, also known as MAH001. And with that grant, we've done some other things we'll talk a little bit about here. So I'm going to turn it back over to Monica, though.
So this is one of the sheets that was on your chair, and this is just to kind of make everybody aware of all the resources that are available across the state. IDPH funds through the Substance Abuse Prevention and Treatment Block Grant 23 different providers, and this is the map of their catchment areas. So people across the state are able to access treatment for a substance use disorder of any kind through these providers. Now, only 4 of these providers were awarded our special MAH001 grant, so they have kind of above and beyond services available that they are able to use those funds, like we'll talk about here in a few more minutes. But we are looking at expanding that accessibility through our newest grant. So just wanted to make sure that you had, since public health does work across the state and many of your programs probably touch different areas of the state, this would be helpful for you to look at.
Okay, so we're going to talk about some of the different efforts. The first one we're going to talk about is MAH001. This grant is, again, as I said, we received this in 2015, and one of the goals of the grant was to increase the use of medication-assisted treatment. And how we did that is we identified the 10 highest need areas or 10 highest need counties in the state and used opioid prevalence data, things like opioid overdose, treatment admissions, and things like that to determine who were the 10 highest need counties. And then what we did from there is we made 4 awards, and those those providers are United Community Services, which is in Polk County, Jackson Recovery in Sioux City, ASAC in Cedar Rapids, and then Mercy Turning Point in Dubuque. Now, originally when we offered this grant opportunity, we made it eligible to only block grant funded providers. Mercy Turning Point is not a block grant funded provider, but Dubuque has been especially hard hit in regards to opioid overdose and usage. So what they did is they entered into an agreement with the block grant provider in that area and submitted a joint proposal, and we honored that just based on the quality of the application and the need in the area.
And so we have the expert on this grant here in the room, Janet Nelson manages the SPIF-RX grant. So that stands for the Strategic Prevention Framework, that's the SPIF part. And then for the prescription drugs, prevention especially focused on young people and preventing prescription drug misuse. So you may have seen these billboards out and about. They're across the state. We saw one in Sioux City last week. And she also has developed, as part of this grant, a short video PSA that we're going to show now, hopefully. Maybe it worked before when no one was in the room.
Work for that.
We have to help her.
Hey, Sam, can you hear me? Looks like an overdose. Do you know what she was taking?
She doesn't do drugs. Her friends don't do drugs.
No, we're just trying to save your daughter's life. Any idea?
Go to the movies, hon. See you later.
Bye, Sam. Sam, wake up! Okay, so that is the PSA that has been developed, hopefully to kind of make people aware of the overdose potential, and that even young people that you would think, you know, are very straight-laced, well-adjusted, that you wouldn't suspect of something like this, have been shown across the country to be using prescription drugs. A lot of young people think because they're prescription, they're safe, and so, you know, nothing bad can happen, which is clearly not the case. So, if you have questions or want to get involved in any of your local communities, feel free to ask Janet about more opportunities for that. The next grant that we recently got, just started in May of this year, and this is the State Targeted Response, so that's what STR stands for. All of the states were awarded formula funding for this grant, and IDPH here received $2.7 million for each year of the 2 years that it is supposed to run through. So our goals with this grant are really to expand access to the medication-assisted treatment that you heard Kevin talking about, that are already available in 4 communities in the state, and also make sure that this is being done in kind of a thoughtful and planned process through a community needs assessment and strategic plan specific to how that community is dealing with opioids. And then we also want to support the statewide use of both Janet's media campaign that you just saw the PSA from, as well as some kind of additional pieces that target up into the adult population as well, because we do see that the target of focus with opioids tends to be people between 18 and 44 years old. And we're also working with the Board of Pharmacy and are excited to be able to partner with them to help support the enhancement to the prescription monitoring program that they're doing. So that's what the PMP is the prescription monitoring program. And we could do a whole 45 minutes on that, but we won't. So, so needless to say, we're excited to partner with them. Then the last point on this grant that we're addressing is to make sure that Narcan or naloxone is available and accessible across the state. Dr. Quinliss has done a huge favor to the state by creating a standing order for naloxone to be available at pharmacies. And that means that if someone wants to purchase it, they don't have to go to their own doctor and say, will you write me a prescription for Narcan because I'm afraid that my best friend might overdose or something to that effect. So Narcan is the overdose reversal drug, which they were about to administer in that PSA. And it helps to, basically in the brain, it bumps the opioids out of the opioid receptors. Because when there are too many opioids in the brain, it can reduce the breathing to a point where they stop breathing. And so the important job of Narcan or naloxone is to bump the opioids out and occupy that space so that the person is able to resume breathing. What we've found, unfortunately, with a lot of the opioids that are of even higher potency, is that the opioid lasts longer in the brain than the naloxone does. And so naloxone wears off and goes away after sometimes a half an hour or so, and the person could slip back into an overdose at that point, which is why it's very, very important that if anyone comes across someone in an overdose situation, you need to call 911 and make sure that they get emergency medical attention for that reason, among others. So if there are other questions about that, Kevin can answer them because he's the expert on Narcan. So one more trivia question. What are some pain reduction or pain management alternatives to opioids that are supported by research? Does anyone know? Yeah.
Meditation, massage, essential oils.
Those are a lot of the complementary and alternative medicine approaches, yeah.
Were you guys able to hear that?
Oh, yeah.
Meditation, massage, okay.
Yeah, she mentioned meditation, massage, essential oils, among other things.
Acupuncture?
Acupuncture, yes, that's another one. Yoga.
Physical therapy.
What's that?
Music therapy.
Music therapy. I don't even think that's on the list, but yeah, that's good.
They did that at the University of Iowa Hospitals.
Yeah. Others? Did somebody say something
Physical
else?
therapy.
Physical therapy?
How about non-opioids?
Non-opioids, yeah. So all the pain medications that are non-opioid, yep.
Similar, I was going to say over the counter to analytical.
Right, right. Great. So yeah, I think we covered them all. So really any kind of exercise with flexibility training. The middle bullet we did not cover. So the cognitive behavioral therapy approaches. Those are techniques that can be learned with a counselor that really help people. It's a lot like mindfulness and other kind of processing the way you're thinking about the pain and how to manage it. It sounds like it wouldn't work, but it actually does and has been supported by research. So yeah, there are a lot of different ways to manage pain and reduce pain. Not all of them work for all people, so it's important to work with your healthcare provider to kind of explore any options that might be out there.
Do you know if any of these work for people that have become addicted to opioids, like, you know, in combination with some of the medications we give people? Do these alternative therapies support people as they're sort of...
Yeah, so the question was if these work in people who've become addicted to opioids and if they assist with the medication-assisted treatment. And yes, basically all of these alternatives or approaches can be used, and many are used in treatment centers as additional approaches. Cognitive behavioral therapy is one of the kind of tried and true strategies for counselors to use. So it's been very well documented to be effective. And in combination with medication, we find that the more traditional treatment approaches are made much more effective when both medication and treatment are provided. So it's much more effective than just medication alone or just treatment alone. And then I just wanted to let you know there at the bottom that there is a new combined website that will be launched hopefully August 1 for the behavioral health topics that are currently on separate websites. So this will include Iowa-specific resources for alcohol, drugs, problem gambling, and suicide. And all the resources that are specific to that through the department here will have a home at the Your Life Iowa website. So be looking for that in August. And Kevin's going to talk about the other efforts that we've been working on too.
Well, some of the things that we have listed here we've already talked about. The naloxone standing order, which again, as Monica said, was a huge benefit to the state. Originally, it was introduced as Senate File 2218, basically expanded the access, the ability to administer without concerns or with repercussions. And then it was also followed up by House File 2460, which then expanded the access, as Monica said, so individuals could walk into a pharmacy and be able to purchase the medication there. Still the issue with the purchasing of medication, purchasing of naloxone, because it can be expensive, but that's one of the things that Monica's addressing with the new STR grant, to see what we can do to make it more affordable for those individuals that need it, simply because we've heard that in some cases, because of some of the illicit forms of fentanyl that are out there, 4, 5, and 6 administrations are needed to revive somebody from respiratory depression. And if you look at a 2-pack of naloxone costing anywhere from $75 to $140, it gets quite expensive. We've been working with collaboration with boards of pharmacy, nursing, medicine, and dentistry on communication strategy, trying to get information out to their licensed members about what their role is in regards to the prescription opioid issue. We developed which you should all have, the opioid overdose recognition and response brochure. It took quite a while to get this done, simply because we have so many different individuals, so many different areas that we wanted to have involved and get feedback. But what we've come up with, we're very happy with, and in fact, we just ordered, or I think we just received our second disbursement or second shipment of these. We gave out or sent out all 15,000 of our first distribution. So people were very interested in it. Yes, and we've also added a Spanish edition as well. So we do have this listed or posted on our website, but if you'd like nice printed copies, let us know, and we'll give you whatever you need. Education and outreach on opioids and medication-assisted treatment. We've done several presentations. We've had some television and radio interviews. We've presented to some of the different legislative communities, in addition to some other community forums as well, just trying to get the information out there about what MAT is, how opioid use disorder impacts individuals, who it impacts. As Monica said before, a lot of misinformation or maybe a lot of judgment that when you think of a person that uses an opioid, that you're automatically going to a person that IV uses heroin. And we know that's not necessarily the case. National Governors Association Opioid Learning Laboratory was a technical assistance opportunity that we were given along with 6 other states to learn more about what other states were doing, and also look at what we can do better to improve our efforts in addressing the issue. And then the recovery community organizations. Monica talked a little bit about how medications can be very beneficial to individuals with an opioid use disorder. Treatment can be very beneficial to individuals with an opioid use disorder, and a combination as well. That's the reason I bring that up is because we tend to want to focus on treatment and focus on how individuals can make that change or that intervention occurs. The thing that we don't focus a lot on, at least not in our state, is on recovery. What do we do beyond treatment? And for most people, when you ask them, they'll say, well, 12 steps, AA, NA, CA, those kinds of things. But there's a large number of individuals that don't continue with 12 steps for various reasons, whether it's a co-occurring disorder, whether it's an issue of relation to a higher power, whether it's talking in groups, things like that. And so what we're trying to do with our recovery community organization is develop alternative forms of recovery for individuals in the state, looking at what can we do to support what we call multiple pathways of recovery. We just released an RFP. We're looking at what we need to do to kind of tweak that a little bit, because this is something that we want to see happen in the state. We have some funding allocated in addition to Monica's STR grant. There was funding available for it too. But this is definitely a direction that we want to move with Iowa. Other issues still to address are in process, and unfortunately, when we first developed this PowerPoint, it was probably 5-6 months ago, and these issues are still relevant today. The prescription monitoring program utilization, for those of you, is everybody familiar with the prescription monitoring program or the PMP? Some, yes, no, maybe? Okay, so the PMP, what that is it's basically a database, and Kathy or somebody could probably better explain, but it's a database where prescriptions are uploaded. Currently, I think it's within every 7 days by a pharmacist to this database. So an individual comes in, gets a prescription filled within 7 days, the pharmacist then uploads that information. The benefit or the purpose of that is to provide information on what prescription an individual is receiving, specifically things like opioids or benzodiazepines. Then a physician can go and check that when a person comes in asking for services, and so they can kind of use that as an opportunity to identify, is that person, possibly abusing this medication? Is this an opportunity for an intervention where I can give somebody some help? The problem is, while pharmacists are required to use the PMP and upload the information, physicians are not. And so right now we have about 42% of physicians in the state that are registered to use the PMP, but not all of them are actually using the PMP. So we want to see, more usage of the PMP, because when you think about it, what better way to help save somebody or identify maybe early on in those stages of addiction an opportunity to help them, or prevent doctor shopping, or prevent an opioid overdose.
Okay.
Yes.
I probably was lost. Is this mandatory or not?
The PMP is mandatory for pharmacists to use, but it's not mandatory for physicians. So the question was whether or not it's mandatory. Physicians do not have to use it. The concern is that there's a lot of time that goes into having to access the PMP, research that particular patient, determine whether or not there's any kind of issue with the medications that they're receiving. But every time we go and we talk to a PMP user, we talk to whether it's at an OTP or their physicians, they tell us it takes about 30 seconds per patient. So we're trying to just address the low-hanging fruit, when they're telling us these are the issues. So those are the things that we're trying to address with them. So as Monica talked about, she has funding allocated to help enhance the PMP so that hopefully we can eliminate some of those concerns and make it easier to use for physicians. Next, the Good Samaritan. Good Samaritan, basically that just means that if a person is with another person that's experiencing an overdose and they contact law enforcement, if there is the presence of any kind of illegal activity or some illegal activity, the person that calls isn't going to be prosecuted as a result. The problem is that we still have this barrier of getting information. We had a couple different bills that were introduced last legislative session. And the reason I say this is because there's acceptance, and I'm sure everybody's aware of this, of stigma when it comes to people that still use opioids. We talked a little bit about that before. We tried one bill where we got Good Samaritan information included, but that was quickly tossed out. But then there was another one that was introduced, and I guess the mindset was that, okay, we're supporting Good Samaritan, but only if you take opioids out. We don't want it to just apply for alcohol. So there's still some education and some intervention that we need to help provide to legislators and others, because when you look at the number of opioid overdoses that we had, provisional data for 2016, we've had 86 opioid overdose deaths. That's overdose deaths, meaning that the opioid was identified as the primary cause. We have a total of 180 opioid-related deaths in 2016, meaning that opioids were found in the system, but it may not have been the primary cause of death. So it could have been a car accident, drowning, things like that. Individuals are still afraid to call and get people help. It's kind of seen as, you know, we're being soft on crime. We just want to help save people's lives. So it's we've still got kind of our work, you know, made out for us, but hopefully, because there was some movement with the previous session, we can do that again. Syringe Services Program, often referred to as a needle exchange program. The reason we say Syringe Services Program is because syringe services is much more than just needle exchange. When you talk about needle exchange and you have a legislator that you're having a conversation with and they hear that, why would I pay for a junkie to have clean needles? Well, it's not paying for clean needles. That's a part of it, but it's also looking at what can we do to help, you know, stop the spread of infection. You know, let's look at, can we do hepatitis testing, HIV testing there? Can we offer peer support? Can we offer other opportunities or linkages with primary care? The list kind of goes on and on and on, but it's just it's an opportunity for individuals to receive more help than just clean needles. Again, that particular piece of legislation was quickly kicked out again. The thing that's preventing us mostly with that is that syringes are listed as paraphernalia. And so that's the biggest barrier that we're having right now. If we could just get that, just get that removed, then we'd have a lot more traction. I think we'd see a lot more of those services being provided. Finally, insurance coverage for services. Just when we think we're making progress, we experience setbacks. Iowa traditionally has been known as a non-Medicaid funded methadone state. I mentioned, you know, we had this National Governors Association that we were involved in, and I shared that during one of the meetings because we had DHS representation there, and they said, oh no, we pay for that. Well, I waited for documentation and waited for documentation, they never got it to me, but then we had a provider saying, hey, we're getting reimbursed for Medicaid. Great. So we thought that, you know, maybe this is finally passed. We just had a conversation with another OTP a couple weeks ago saying, we're told by Medicaid that there's no such thing or no funding for medication-assisted treatment. So we're trying to get something concrete that we can quote, send out, you know, distribute to others, because that is a barrier. When you think about methadone, you know, even if it's cash, you know, which quite often with some of our OTPs, that's the only way that they're funded, it's about $80 a week. So if you're thinking $320 a month for an individual that, you know, is barely scraping by or meets eligibility for Medicaid, but Medicaid won't pay for it, where do you think that $320 is going to go? Chances are it's not going to go to methadone, which is unfortunate because those are the individuals, you know, that could benefit from it. So still some work to work on. Finally, that's who we are. Our boss, Kathy Stone, Deanne Decker's our bureau chief, and then Monica and I are listed there below. So if you ever have any questions, or if you have any questions now, please feel free to ask, and we'll try to make up something. Yeah.
Does private insurance cover like Blue Cross, or is it just, is it just Medicaid that you're mostly running into struggles with?
Yeah, so the question was, does private insurance pay for medication-assisted treatment? It pays for some. We hear different responses from different insurers. Blue Cross has been very good to work with. When it comes to naltrexone, we were just told, I think by a provider, that Blue Cross was actually charging the Vivitrol injection as a copay. So when you think about a $1,200 to $1,500 shot every 30 days, that now I can just go in and pay a copay for, that's huge. Yes?
So what outlets are available for people that have excess medications? I mean, as far as getting rid of them?
So there are prescription drug drop-off locations, and there's actually a map on the Office of Drug Control Policy's website. But there are locations in almost every county. Most of them are either a pharmacy or a police department. Here in Polk County, I believe at the city police department, there is an opportunity to drop off unused medications. But if you ask at your pharmacy and say, hey, I have some leftovers of old prescriptions, what should I do with it? They can always tell you the best kind of usually quickest plan. Because they don't want you for sure to put them down the toilet. That just messes with our water supply. And they do say that some people, it tends to work if you dump them in kitty litter or something that people wouldn't want to paw through to go through your garbage. And throw them out that way. So, yeah, good question. Yeah.
Yeah, I saw in the handout the section about why the increase
Mhm.
and how we've been really steadily increasing since 1999.
Yeah.
But why would you say just in the last 6 months that this has become such a big emerging need?
Mm-hmm. I think that it has been growing steadily over the last few years, and upstairs at least we've seen an increase in requests from the media and from legislators in different places. I would say in the last 6 months, with the announcement of the funding for the state targeted response, we've seen a lot more interest just from a wider variety of types of people. But I think because it's kind of hitting that tipping point of media coverage as well as people being affected. So, most people know about AA and about treatment for alcohol and other drugs because they know someone who is affected by an alcohol use disorder. It's so common. Alcohol is still by far the #1 drug that is used and misused and leads to use disorders. And so because this is starting to really touch more and more people, and people are aware of someone that they know who's been affected by a close family member, I think it's getting a lot more attention. Yeah.
Do you know of some medications that might be for migraine and can lead to opium?
She asked if there are medications for migraines that might lead to a use disorder or addiction. And really any of the opioid medications. So on the medication it should say whether it's an opioid or not, or you can ask your pharmacist when you get your medication. You can also Google it to see if your particular medicine that you use is an opioid. There are a lot of different kinds, and some may be used for migraines, although I'm not aware specifically of migraine medicines as a class, so I'm not probably qualified to tell you. Yeah.
Monica, it seems like all the efforts statewide and nationally are on treatment. Why isn't there more of a push to just not prescribe opioids and send you home with a prescription for Advil?
Right. So the question was why is the focus more on treatment and not on stopping the prescriptions of opioids and using other options? I think that has been a small part of the push that we've seen. The CDC released, was it last year? 2016 guidelines, new revised opioid prescribing guidelines for healthcare providers. And that was a pretty big deal because the change had come on fairly slowly over the last 20 years or so, that pain was really being looked at as kind of the 5th vital sign, and that if healthcare providers weren't taking care of your pain, even if they were taking care of everything else, it was not okay. And it was included in one of the metrics that healthcare providers are evaluated on, and even reimbursed at some levels. So that really made it an incentive for your healthcare providers to make sure that you were not in any pain. And that is one of the things that led to the possible, overprescribing of pain medications, including opioids. And so when the CDC came out with the new guidelines, there was a lot of surprise and or pushback from providers saying, well, if we don't prescribe, then people are going to complain because they're going to be in more pain. And they don't want to be called at 2 o'clock in the morning when your pain meds wear off and you're in agonizing pain. And so there's a variety of reasons, but I think the more research that's being done on non-opioid pain relief, the more popular that those different categories of managing pain are becoming. And also because I think the reason we're not getting rid of opioids altogether is because they are a very powerful medicine. And they can do a level of pain relief that Advil can't. And so that's, as far as I know, the main reason.
And just to add, one of the things that we've encountered or that we've heard as well is that to prescribe a opioid and have a person go and have that prescription filled, they could get it filled for as little as $2. But if you want to try and look at some of those other options that we talked about as far as dealing with pain, like physical therapy, chiropractor, yoga, things like that, there's a much higher significant cost. And so when you talk to an insurance company about trying to address an issue, quite often they're going to go to the least costly alternative. And so there's this philosophical change that I think that needs to occur. When you look at the fact that the United States, accounts for 5% of the world's population, yet we utilize nearly 100% of the hydrocodone prescribed in the world, there's an issue there. And so we need to look at what are some other alternatives to addressing pain, the NSAIDs, non-steroidal anti-inflammatories, those kinds of things that we need to be looking at. But again, we've got this mindset, take a pill, pain's gone, no effort on my part, and then I'll be all better. And again, with insurance companies as well too. I think it's going to take a joint effort, physicians, legislators, family members, treatment professionals, trying to push this effort forward.
And I would also like to add that there's prevention also. We're in the prevention department that's also with treatment. And so ours is on the front end, trying to educate and let people know that prescription drugs are addictive and dangerous and there are alternatives. So it kind of works hand in hand with treatment.
Don't you think they're kind of, I'm sorry, but I just got to follow up on it. Don't you think there has to be a change of the mindset of us, like human beings too, that, okay, I have a headache. You're in pain sometimes.
Yeah. Suck it up, Buttercup.
Right.
Yeah.
No, I do. I think, I'm not going to say we're a society of, wimps, because there is legitimate pain. But I think that we've gotten to a point, and I think, physicians play a role in this, but I don't think the physicians can be vilified because of that, because as Monica said, there was a lot of push by Big Pharma. Research that was being cited wasn't, accurate, and so we've kind of gotten into the system of, unless I want to be challenged by my patient, I need to treat their pain better, and that means no pain, quite often to them, or at least that's their definition. I had back surgery several years ago. I still have pain today, but I choose not to take an opioid. I choose to try and exercise and do things more productive, as opposed to going down those alternatives. Monica does yoga every day at some ungodly hour in the morning. But again, it's a way to address sports-related injuries and things like that. So it's a mind shift that needs to occur. Yeah?
How do we range in comparison compared to the rest of the nation for using?
As far as Iowa? Yeah, so the question was, how does Iowa compare to other states? We are a relatively low incidence state when you start to look at number of opioid overdose deaths or related deaths. However, the issue for Iowa is the rate of increase. We're looking at how have things increased over the course of the past few years. And in many cases, some of those treatment admissions, I think, have increased 200% since in the last decade. The overdoses have increased as much, if not more. And when we start looking at those opioid-related deaths, the numbers are very scary. Again though, in comparison to Ohio in 2015, they had 3,050 overdose related or opioid related deaths. So nowhere near what's going on in other states, but again, we don't want to get to the point where we're having several hundreds or thousands of deaths each year. So whatever we can do to kind of intervene early on, prevention, treatment, other opportunities, we want to do that. Going once, going twice.
Thank you
All right,
for a great
thanks.
presentation. Our next, you can clap first. Our next bus stop next month is HIV and what they are seeing and what the programs they are doing. And there is a correlation between hepatitis C increases and the opioid crisis. So thank you guys for a great presentation. Now we clap. You'll get a link to your evaluations. Thanks, you guys.